Can we have our next speaker, Dr. Haripriya Arvind?
Good morning. My paper is titled Comparative Analysis of SC Depot Steroid to Using Topical Steroids and NSAIDs in Phacoemulsification. We all know the trouble with using eye drops. This could range from issues with compliance to improper application to mix-up of eye drops. This is especially a problem for all patients undergoing phacoemulsification to use their routine topical steroids and NSAIDs following surgery. So some surgeons have injected different doses of depot steroids, either subconjunctival or subtenons, and this is the range they have used between 4 milligram to about 40 milligram, and this varies based on how far it is injected from the limbus. So we are using the dosage of 4 milligram in 0.3 ml as per Dr. Neil Shorstein's recommendation, and this is given about 6 millimeters from the superior limbus. So this is the preparation of the injection. So we use the unpreserved triamcinolone. We draw in 1 ml, which has about 40 milligram of the drug. This is diluted with 1 ml of distilled water, and from that we draw in about 0.3 ml. So this makes it about 6 milligram. And this is injected in the subconjunctival space using a 30 gauge needle. This way we don't have any reflux. Insert about at least 2 or 3 millimeters, 6 millimeters from the superior limbus. So the purpose was to compare the efficacy and safety of single subconjunctival depot triamcinolone acetonide with topical steroids and NSAIDs after uneventful phacoemulsification. So this was a prospective, multi-centric, amongst the 3 centers of Arvind Eye Care System, randomized control trial. Most of the previous studies were either retrospective or had small numbers, even if they were done as a RCT. So group A included about 200 eyes of 200 patients who received Tricot 6 milligram in the superior limbus, and group B included 202 patients who received topical pred acetate for 6 weeks tapering doses and dipephenac for 3 times a day for about 1 month. All patients in both groups received topical ofloxacin and intracameral moxifloxacin, and the follow-up was 15 days, 45 days, and 90 days post-op. We did not include patients who were very young, less than 40 or over 80 years, known cases of glaucoma, family history of glaucoma, high myopes, any significant ocular comorbidity, or any intraoperative complications like a capsular tear or posterior capsule rupture. Looking at the demographics, both the groups were comparable in terms of age, gender, and the laterality. The best corrected visual acuity was analyzed, and the preoperative visual acuity in both groups was 615, which improved to 4.8 in both the 45-day and the 90-day follow-up. And this difference was not significant because the visual outcome was very similar. We looked at the intraocular pressure, and again they are both comparable in the pre-op as well as in the final follow-up. It reduced by about 1 millimeter in the final follow-up compared to the pre-op, and there was no issue with glare. We had 1 patient where we had to remove the depot because of sustained IOP spike. The postoperative inflammation, which required additional medication, were 2 patients in the subconjunctival steroid group and 4 patients in the topical steroid group who required more medications compared to what they were already using. We also looked at macular thickness, and the mean macular thickness was 189, 191 in both groups, again not statistically significant. 1 patient of CME was noted in each of the groups. So in conclusion, a single dose of subconjunctival triamcinolone acetonide injection was found to be safe and effective and non-inferior to topical steroids and NSAIDs following phacoemulsification.
Should I ask? Ma'am, very nice presentation. How long did the subtenon steroid stay before it actually went off? Because you must have followed up beyond the period of the study.
Yeah,
right?
so this was 90 days. So I think most patients, at the last 90-day follow-up, we had the depot in about 30 patients.
Out of the?
Out of the 200.
200.
Yes.
So about 15% had retained.
Yeah, and also that was also not like, I think it was more the vehicle, it was a very less small quantity.
Right.
But the good news we found with this sample, that the main thing was the dose was seeming to work. So earlier before this, we have done it in many patients. We compared 4 and 6 milligram.
Right.
4 seemed to be inadequate. Some of them had inflammation rebound. Whereas this dosage, we were concerned if stepping it up would have an IOP spike and glaucoma. We did not see that as a major problem.
Did you rule out any systemic problems in the patient like diabetes or anything?
So diabetes we included, I didn't have it added here, but with any patients less than 5 years of diabetes we included. Over 5 years we did not, because we just did not want to have any patients with CM, because visual acuity was our main outcome variable.
Right. Thank you.
Ma'am, I understand the need of this study, and did you choose those patients where follow-up was doubtful, or just any patient it was in a sequence?
No, this
it
was a
chosen?
properly done randomized control trial with all the consent form from pre-op and prospect.
Both free or paying?
I chose all the paying patients.
Paying patients.
This was kind of our standard of care. We've done it for over 1,000 patients before this. So I was not doing it as a trial. So I knew that this was working, but I think unless an RCT is there, we would not know for ourselves and the rest if this is actually safe, or at least non-inferior to topical. Of course, the compliance is an issue, but at least it should not have worse for the patient. So that is why this study was designed.
Topical antibiotic was used in these cases?
Topical antibiotics was used in both groups.
As usual?
Yes, we did not change the antibiotic part. And we used the intracameral moxi, which is again our regimen. The group which got the depot did not have any topical steroids or NSAIDs, whereas the control group had both prednisolone and the nepafenac.
So this was subconj, so in comparison to subtenons. So means because effectivity is there, so definitely intraocular penetration might have been there sufficiently. So IOP spike was seen in one case only?
No, IOP spikes we saw, I think only one patient we removed it, because we tried one AGM and the patient was also not happy that they had a depot. So we also give them an information that they're going to have this depot, just to keep the patient informed. They were not happy to see that depot, and that was not, that caused some irritation to that patient.
Like this color.
Yeah. That's why we go superior, because then the patient does not feel concerned. Inferiorly it's more visible, but superiorly they can't see it.
Thank you, ma'am.
So, ma'am, did you rule out steroid responders prior to injecting?
Yes, so we removed steroid responders. Anyone who was on, any diseases who may need steroids, like any autoimmune disease, all those patients we excluded from the study.
You excluded from it.
Any family history of glaucoma, all of them excluded.
Thank you.
Thank you.
One question, ma'am. Was there any difference in ocular surface discomfort symptoms?
Yeah, so we also measured that between the two groups, and surprisingly we did not see any difference, though we expected. So we asked them 4 points in terms of pain, redness, irritation and all that. The discomfort was surprisingly similar in both the groups.
And did the patient in whom the depot was removed, did the patient respond?
Yes, it is actually a very easy thing. So just subconjunctiva, you just have to nick it and get it out. So it's very straightforward, and the patient was fine, and there was no issue with that.
Asking because excising a subtenon's depot.
This is subconjunctival, so it's very easy to remove.
Right.
It's like just conjunctival, you just resect it. It's very easy, and patient also was fine. There was no issue at all.